very last session of the day is going to be another physician-patient perspective video series. And this will have 3 videos in it. And John, do you want to?
Yeah, sure. So section 5 is bacteria in the GI tract, and we're going to focus on SIBO and H. pylori. And we're fortunate to have Bill Chey, who many of you have already been introduced to this afternoon and morning. Bill is obviously an expert on H. pylori and is going to share some new updates on H. pylori, and I think that's going to be an excellent session. We're going to move on to Dr. Darren Brenner, who's also one of my colleagues at Northwestern, one of my faculty, who's going to focus on small intestinal bacterial overgrowth. He's an expert in this, runs our motility lab at Northwestern, and is really well known for his work in breath testing in terms of SIBO. And as Cecile mentioned, we're going to finish this off with a patient perspective, and our patient will be Tina Aswani Omprakash, and she's going to be talking about how she's been living with SIBO since 2015, and also talk a little bit about some of the stuff that she's gone through in her childhood. So really, once again, keeping with the model of the patient with the physician, looking forward to this session.
Absolutely, and we hope you enjoy it.
Hello, everyone. My name is William Chey, and I'm a professor of medicine and nutrition sciences at Michigan Medicine in Ann Arbor, Michigan. I'm so pleased to join you today to talk about Helicobacter pylori infection. Before I start the talk, I want to thank the IFFGD for involving me in the Norton Education Series. I'm so excited to participate and to tell you about this very interesting story of H. pylori. As we start the discussion about Helicobacter pylori, we have to go back a number of decades to discuss the timeline, the history of peptic ulcer disease. Remember that ulcers are these punched out abnormal areas in the stomach and first part of the small intestine called the duodenum that can lead to significant bleeding or even rupture of the wall of the stomach or duodenum. It's what we call perforation. And for years and years, decades, and for decades, in fact, the dictum for the cause of peptic ulcer disease was no acid, no ulcer. In other words, doctors and scientists felt that ulcers were resulted from excess production of acid in the stomach. And so, not surprisingly, the attention in terms of development of treatments were all aimed at trying to figure out a way to neutralize or reduce acid production in the stomach. In fact, the earliest treatments involved the ingestion of dairy products like milk or the ingestion of eggs, so-called sippy diet, that was thought to neutralize acid in the stomach. This led to the development of something called the doll's milk drip, where a tube was actually placed into the stomach and milk was dripped into the stomach in the hopes of neutralizing stomach acid and in that way helping with ulcers. Just before the turn of the 20th century, surgeons began to do operations where they actually would resect the part of the stomach that was responsible for producing acid. And then in 1943, surgeons figured out that they could actually cut a nerve leading to the stomach called the vagus nerve, which is responsible for stimulating the cells in the stomach that produce gastric acid secretion. So by cutting this nerve, they could actually lead to a reduction in acid secretion. And then putting 2 and 2 together, surgeons figured out that they could actually resect part of the stomach and cut the vagus nerve and potently reduce acid secretion. By the 1960s, physicians and scientists had figured out that they could use antacids instead of surgery to neutralize stomach acid, and also medications that were available at that time called anticholinergics, which are medications that inhibit the stimulation of the stomach to produce acid. Now, unfortunately, these therapies didn't work very well, and also they could lead to significant side effects. So anticholinergics led to drowsiness, constipation, a whole host of different side effects, which were quite unpleasant for patients. In the 1970s and 1980s, there was a very important discovery of a class of drugs called the histamine 2 receptor antagonists. These were drugs that actually more potently and for longer periods of time inhibited the production of acid in the stomach. And they were thought to be revolutionary in terms of the treatment of peptic ulcer disease and also conditions like gastroesophageal reflux disease. In fact, these H2 receptor antagonists like cimetidine, which is also known as Tagamet, or ranitidine, also known as Zantac, were some of the first blockbuster drugs. These are drugs that actually accounted for more than $1 billion in sales on an annual basis. Then, in 1982, Robin Warren and Barry Marshall turned in a very important scientific report where they suggested that the primary cause of inflammation and ulcers in the stomach and duodenum, so peptic ulcers, the primary cause of peptic ulcers was a bacteria called Helicobacter pylori. Helicobacter pylori is a spiral-shaped bacterium that lives in the mucus overlying the lining of the stomach. Now remember that the stomach, because it produces lots and lots of acid, was for years and years thought to be a sterile environment. In other words, no bacteria were thought to be able to live within the harsh acid environment of the stomach. But this particular organism, Helicobacter pylori, figured out a way to burrow into that mucus gel overlying the lining of the stomach, and in that way protect itself from the very harsh acid environment of the stomach. And the discovery of Helicobacter pylori and its association with development of intense inflammation in the stomach, and eventually, for some individuals, development of peptic ulcer disease, led to a so-called paradigm shift. That is, a complete change in the way that we thought about peptic ulcer disease, from this dictum of no acid, no ulcer, to peptic ulcer disease and gastritis being an infectious disease, not unlike syphilis or strep throat. Now, as you might imagine, the scientists and also industry that had been benefiting or had put forth this idea that ulcers were the consequence of acid, and now a multi-billion-dollar industry of producing drugs that suppress acid production in the stomach. There was a lot of resistance to this idea that gastritis and peptic ulcer disease were infectious diseases. And in fact, Barry Marshall and Robin Warren put up with a lot of negative feedback as they tried to put this idea forth that led to this paradigm shift in the way that we think about gastritis and peptic ulcer disease. In fact, when they were eventually borne out to be true, they actually received the Nobel Prize for Medicine in 2005. And I want to share with you this story. When Barry and Robin turned in their original report of a series of patients in which they observed this unexplained bacteria overlying the stomach lining in individuals with this intense inflammation in the stomach, they turned this report into the Gastroenterological Society of Australia, and they received notification in regards to their presentation in the form of this letter, which said, "I regret that your research paper was not accepted for presentation on the program of the annual scientific meeting for the Gastroenterological Associate or Society of Australia to be held in Perth, Australia in 1983. And if you hone in on this next section, the number of abstracts we receive continues to increase. And for this meeting, 67 abstracts were submitted, and we were only able to accept 56. So of the 11 abstracts that were not accepted to this meeting, it turns out that one of them accounted for the Nobel Prize in Medicine in 2005. So something to take away from this, a remarkable story of determination and even stubbornness that led to a paradigm shift that helped us to recognize that in many patients, inflammation in the stomach and peptic ulcer disease is actually an infectious disease. So let's turn our attention now to H. pylori infection. H. pylori turns out to be one of the most prevalent infections worldwide. In fact, more than half of the world's population is infected with this particular bacteria. In the United States, that prevalence is a bit lower, but still, a third of people in the United States are infected with H. pylori infection. If you look at this map which depicts prevalence of H. pylori based on geography, what you notice is that the southern states in general have higher prevalences or a higher rate of H. pylori infection than the northern states. And this is particularly true if you look at the rate of infection amongst African Americans, Latinxes, and Asians, where the infection rate is higher than in American-born Caucasians. In fact, it's been argued that one of the biggest drivers for H. pylori infection in the United States in the coming years will actually be immigrants. Now, there are a number of clinical consequences related to chronic H. pylori infection. I reviewed some of them with you already. The idea that the most common cause of gastritis is H. pylori infection. A very common cause, the most common cause, identifiable cause of peptic ulcer is also H. pylori infection. But very importantly, H. pylori has now been assigned the designation of a class 1 carcinogen by the World Health Organization. So in other words, H. pylori seems to be associated in the pathogenesis or development of gastric cancer. Now, the good news is that only a very small minority of patients develop peptic ulcer disease, probably 10 to 15% at most of individuals with H. pylori infection will go on to develop an ulcer at some point in their life. Most of the time, they won't even know. And an even smaller, infinitesimally smaller percentage of individuals with H. pylori infection will go on to develop gastric cancer. But nonetheless, one of the most common identifiable causes for gastric cancer is H. pylori infection. There are also a number of other diseases which have been associated with H. pylori infection. So patients with unexplained upper abdominal pain or dyspepsia, it turns out that H. pylori infection is a potential cause for those symptoms. Also, individuals who are starting therapy with aspirin, so like if you had a heart attack and you get started on aspirin, or non-steroidal anti-inflammatory medications, so things like Aleve or Motrin. So if you have arthritis or back pain and you're having to use those medications, individuals with H. pylori infection that use aspirin or non-steroidal medications are more likely to develop an ulcer than individuals who are using those medications without H. pylori infection, or even have H. pylori infection without using the medication. So the presence of the infection and those medications seems to play off one another to actually more than double your risk of developing an ulcer. Also, individuals with unexplained iron deficiency anemia, turns out that H. pylori can cause that or has been associated with iron deficiency anemia. And finally, idiopathic thrombocytopenic purpura, a condition where the platelet count is low for reasons that aren't apparent. H. pylori infection can also cause or has been associated with that condition. There are a range of different diagnostic tests which can identify if a person is infected. So tests that don't require endoscopy and tests that require or can be performed at the time you undergo endoscopy with an endoscope. The tests that don't require endoscopy can utilize blood to identify antibodies to the infection, breath samples to identify metabolic consequences of H. pylori infection, or finally stool testing to look for antigens or proteins that are shed by the bacteria that lives in the stomach. For endoscopy, there are tests that again can identify the metabolic activity associated with the organism. There are special stains that one could use to directly identify H. pylori organisms. And then there's culture, where you actually grow the organism in a petri dish with certain types of media. Now, in general, we're moving away from using blood testing to identify antibodies, and really focusing our non-endoscopic tests on either breath tests or stool tests. Those are the most accurate tests. And if you're getting tested for H. pylori infection, the best test to get, if you're not getting endoscopy, are a breath test or a stool test. If you get a breath test or a stool test, you should make sure that you haven't taken a proton pump inhibitor like omeprazole, lansoprazole, pantoprazole for 1 to 2 weeks before you get tested. You should make sure that you've been off of bismuth or antibiotics for any reason for at least 2 to 4 weeks. Treatment for individuals who are found to be infected consists of 2 to 4 drug regimens. Invariably, these regimens contain a proton pump inhibitor. So again, drugs like omeprazole, lansoprazole, pantoprazole, and then some combination of 1 to 3 antibiotics, usually drugs like amoxicillin, clarithromycin, tetracycline, metronidazole, levofloxacin, or rifabutine. And it's very important, even if your doctor doesn't ask you, if you're getting started on a treatment for H. pylori infection, to avoid antibiotics that you previously received for any reason. So let's say for the sake of argument, you're diagnosed with H. pylori infection, and back when you were a teenager, you received a number of courses of clarithromycin or azithromycin, so a Z-Pak, for strep throat or sinus infection. You should not receive treatment that contains clarithromycin. You should try to avoid that, because if you have H. pylori infection, it's very likely to be resistant to that antibiotic. In general, treatments last for 14 days. It's very important to make sure that you take all the medication as prescribed for the proper duration of therapy, because here's the thing, your best chance to get rid of this infection is with your first try. If you don't get rid of the infection with the first try, it gets progressively harder and harder to get rid of the infection with subsequent courses of therapy. So being disciplined and taking all the medications for the specified duration of treatment is critically important to making sure that you successfully eradicate this infection. So to summarize, H. pylori infection is one of the most common human infections. In the United States, about 1/3 of Americans are infected with this particular bacteria. H. pylori is an important cause of inflammation in the stomach, also known as gastritis, peptic ulcers, so ulcers in the stomach and first part of the duodenum. It's also been implicated in the development of an increased risk of gastric cancer and unexplained upper GI symptoms, particularly upper mid-abdominal pain. There are blood, breath, stool, and endoscopic tests to identify H. pylori infection. In general, you want to stick to the breath tests, the stool tests, and the endoscopic tests, and stay away from the blood tests. Treatment consists of regimens containing 2 to 4 drugs given for 14 days. And by the way, there are a number of highly effective new therapies which have either recently become available or will be becoming available in the next couple of years. Patients treated for H. pylori should undergo a test to make sure that the infection is gone. This should be done no less than 4 weeks after completing a course of therapy. So I hope you've enjoyed this talk. I hope you've learned something about H. pylori infection, about being stubborn and persistent and advocating for yourself. And I hope you enjoy the rest of the Norton Education Series 30th anniversary program. Thank you very much.
My name is Darren Brenner, and I'm an associate professor of medicine and surgery in the Northwestern University Feinberg School of Medicine. I'm honored to be presenting this discussion on intestinal overgrowth on behalf of the International Foundation for GI Disorders 30th Anniversary Patient Symposium. And over the course of the next 10 minutes, I'm going to tell you a little bit about what we know, don't know, and what we think is overblown with respect to intestinal overgrowth. So let's begin by talking about something we thought we knew. And historically, we thought that our bodies were made up of more organisms or bacteria than actually human cells. Although over the course of the past few years, that's become contested. What we certainly know is that the number of organisms in our GI tract increases as you move farther down the system. So if you look in the more proximal GI tract, like the stomach, you're going to find between 100 and 1,000 colony-forming units of organisms per milliliter. But down in the colon, you'll see more than 1 trillion. We also know that the types of bacteria change as we move down the GI tract. In the upper part of the GI tract, we know what we see organisms that are aerobic, meaning that they need oxygen to replicate and survive. Whereas in the more distal GI tract, like the colon, these organisms are anaerobic. They don't need that oxygen, and the oxygen may actually be toxic to them and kill them. One thing we know for sure is that the biological diversity of the GI tract increases as we age. We also know how to define different types of intestinal overgrowth. And many of you are probably familiar with the term SIBO, or small intestinal bacterial overgrowth. And this is defined as increased concentrations of colonic bacteria in the small intestine that cause symptoms. Now let's talk about that for a minute. A key point here is that these are colonic bacteria, because many people are under the misnomer that these are foreign or external bacteria, and that's not what this is. Furthermore, this has to be a symptomatic process. We find people all the time that have evidence of overgrowth in the small intestine that are asymptomatic. More recently, we've also had an increase in our lexicon, and we defined a new population of organisms known as intestinal methanogenic overgrowth. And these are organisms that can be found in the small intestine or the colon, and they are not bacteria. They are archaea. They are single-celled organisms, the most common of which is Methanobrevibacter smithii, that can live in both parts of the intestinal system. And thus, the reason we changed the nomenclature is because if they're in the colon, it's not small intestinal. And again, they're not bacteria. Now, when it comes to SIBO and EMO, we do not know the absolute incidence and prevalence of these disorders, but we do know that the incidence of SIBO increases as we age. We also have identified multiple protective factors against developing SIBO, and these are things that can be secreted by different intestinal organs, like the stomach. The stomach secretes gastric acid, and gastric acid can kill bacteria in that organ, and also the proximal small intestine. The liver and pancreas secrete bile acids and pancreatic enzymes that digest foodstuffs for these organisms so that they can't survive, and also can kill the organisms as well. There is normal small intestinal motility. Things in your GI tract are pushed antegrade or downstream. That's how food gets from our mouth to our anus. And remember what I said about SIBO. These are colonic bacteria that have to move upstream, like a salmon swimming upstream, to get to where they want to be if they're going to cause us problems. And as long as we have this continued peristalsis, those waves will push these organisms back down towards the colon. There is the ileocecal valve. This acts like a break or a door between the small intestine and colon, impeding the ability of these bacteria to move upstream. And then there's the immune system. There are multiple antibodies and immune cells that can kill the bacteria if they're in the wrong place at the wrong time. So obviously what this would mean is the likelihood of intestinal overgrowth increases intuitively if we lose one or more of these protective factors. So let's say our gut motility doesn't work. We're a patient with diabetes or scleroderma or Parkinson's. Because we do not push as well and force things downstream, we may be at increased risk of developing bacterial overgrowth. Let's say that we reduce our stomach acid, our bile salts, or our pancreatic enzymes because our stomach, liver, or gallbladder aren't working well for a multitude of reasons. This may lead to overgrowth. If we have surgical changes to the anatomy, a lot of patients with Crohn's have to have their ileocecal valve resected, and that increases the likelihood that bacteria can move from the colon to the small intestine. And then there are autoimmune disorders. If patients are taking immunosuppressants or things like HIV/AIDS, where we don't have the immune cells left to fight these organisms. These are just a few of the various reasons why people can develop intestinal overgrowth. We know what the most common symptoms are in these disorders, and the most common symptom overall is bloating, which is the subjective sensation of excess gas within the GI tract. We also see abdominal distension. This is the objective poofing out of the belly, or when you come in and you talk to us and you say, doctor or practitioner, every time I eat, I look 6 to 9 months pregnant. People will also complain of increased production and passage of flatus or gas. We have abdominal pain, nausea, constipation, and diarrhea. And in very severe cases, we can see evidence of malabsorption and maldigestion of carbohydrates, proteins, and fats. We can see losses of vitamins and micronutrients like vitamin B12 because the organisms use B12 as a food source. So they eat it, they take it away from us. We see iron deficiency because these bacteria degrade or break down the absorptive surfaces in our small intestine where we get our iron. And we can see fat-soluble vitamin deficiencies like vitamin A and vitamin D, because if we can't absorb the fats, we can't absorb the vitamins. Now, there are a couple of good ways for looking for small intestinal bacterial overgrowth or intestinal methanogenic overgrowth. And the gold standard you see on the right of this slide. This is aspiration and quantitative culture. We actually take the upper endoscopy or upper endoscope. We push it through your GI tract to the last part of the first part of the small intestine called the duodenum, or the first part of the second part of the small intestine known as the jejunum. And we suck up fluid and we send that fluid for culture. Now, this is cumbersome, it's costly, and it's really only done in a few academic centers because it is very hard to do. You can actually contaminate your sample if you pick up bacteria in the mouth or other parts of the GI tract, which can give you a false positive test, making it seem like you have evidence of small intestinal bacterial overgrowth, but it really isn't there. So what we use a lot of the time, and many of you may have had this test, is what we call breath testing. You take a straw and you blow into a bag or a test tube. Then you drink a sugar solution, usually glucose or lactulose, and you blow into sequential bags or test tubes every 15 minutes for the next 2 hours. And what we can do is we can measure the amount of hydrogen, methane, and hydrogen sulfide that you've blown into these bags. And this is important because human intestinal cells do not produce any of these particular gases. They are produced by bacteria. And that's what helps us determine if you have intestinal overgrowth. Now, hydrogen does not cause symptoms. It is just indicative of small intestinal bacterial overgrowth. Methane, however, has been correlated with a decrease in intestinal motility and thus constipation. And hydrogen sulfide, most recently, has been associated with an acceleration in gut movement and potentially diarrhea. Now, obviously, once your practitioner tells you you have SIBO or EMO, the first thing you're going to do is you're going to go to Dr. Google. And this can be a bad idea because if you type SIBO into the Google search, you'll find that there are almost 6 million results and more than 1.5 million recommendations for diet. There are more than 650 YouTube videos and 322 SIBO books on Amazon. And unfortunately, a lot of these fall into the naturopathic or osteopathic domain. And these people will tell you that you should be taking probiotics, prebiotics, nutricidals, herbicidals. And these really have no evidence to support their efficacy, and they are unvalidated. I'm showing you on the bottom of this screen a website that talks about a group of practitioners who are experts at treating SIBO. And you can see if you want to go through their 2-month program, you can do it for the low, low price of almost $2,400. If you want the 6-month mega program, it's $5,400. And everything that they're showing they do really has no evidence to support it. Furthermore, if you have a program that's really going to take 6 months, why do you offer a 2-month program? And if the 2-month program works, why do you need 6 months? So what really should we be doing to treat these disorders? Well, I think that we should look at the evidence, and here's the evidence from the American College of Gastroenterology guideline on the diagnosis and treatment of small intestinal bacterial overgrowth. And when it comes to SIBO, you can see on the left a chart of antibiotics and the efficacy of those antibiotics for treating this disorder. My favorite antibiotic is rifaximin because it predominantly stays in the GI tract. 99.6% of this never leaves your GI tract. It is safe and tolerable and has the most data to support its use. On the right side of the screen, you see what we have for EMO or intestinal methanogenic overgrowth, and it's newer. This is a nice study that comes from my friend Mark Pimentel's lab at Cedars, where they compared neomycin to rifaximin to the combination of the two. And you can see significantly more patients responded to the combination. The problem here is that EMO will most likely recur and you'll have to retreat multiple times. And neomycin is an aminoglycoside, which means that it can cause kidney damage and deafness. So it's dangerous to use it over and over again. As far as the guidelines concerned, they make no recommendations in terms of treating EMO. So if the antibiotics don't work or you have intestinal methanogenic overgrowth and you're worried about using the combination therapy, what can you potentially do? Well, maybe diet. And there are ongoing clinical trials looking at using the low FODMAP diet for both intestinal methanogenic overgrowth and SIBO, although the jury is still out. And the thought process here is that you'll starve the organisms so that they can't survive. There have been studies looking at probiotics. They do not seem to be very effective. And for SIBO, fecal microbial transplants, and in many cases, this has actually been shown to make the symptoms worse. In my lab at Northwestern, we're trying an herbal preparation called the Trantal. This is a couple of over-the-counter herbals that have been purported to either scavenge methane or kill the organisms that induce methane and potentially reduce the symptoms of EMO. And we're almost done enrolling that trial, and hopefully we'll have data for you soon. So what can I tell you? Let's go back to the beginning. What do we know with respect to intestinal overgrowth? Well, we know that small intestinal bacterial overgrowth develops with a loss of anatomical or functional protective factors. We know that SIBO and EMO are pathogenically distinct. We know that hydrogen correlates with SIBO but doesn't cause symptoms, whereas methane slows down gut motility and causes constipation. Hydrogen sulfide most recently has been correlated to increased movement and diarrhea. We also know that bloating is the most common symptom of these disorders. What's unknown is the best diagnostic strategy. Quantitative culture or breath test, probably the culture if you can get through it appropriately and correctly. With breath tests, there are different substrates. We cannot tell you exactly what the thresholds should be, and there are discrepancies on what constitutes a normal versus an abnormal test. We know as well that the best treatments are antibiotics, but we don't know what to do if the antibiotics fail. And finally, what's overblown are the benefits of naturopathic, behavioral, and dietary cures, which are unsubstantiated at this time by sound and validated data. I'd like to thank you very much for your participation.
Hi, everyone. My name is Tina Aswani Omprakash, and I've been living with small intestinal bacterial overgrowth, otherwise known as SIBO, since 2015. I've had, for a number of years now, a number of digestive ailments. This has really been a family affair for me. You'll see a photo to the right of my father and me. My father was diagnosed with Crohn's disease. He passed away from colorectal cancer when I was 8 years old and when he was 39. He lived with IBS as well, and may have had other functional GI disorders, but the IBD really took prevalence in his case as well as the cancer. For me, was diagnosed with chronic constipation just in the last few years, so IBS-C. But all my life, I can remember having issues with chronic constipation. Since childhood, I used to complain to my mom, who you'll see to the right as well, you know, Mom, like I can't go to the bathroom, and I would have to have laxatives and enemas and all sorts of things just to go to the bathroom. After my father died, you know, we didn't have health insurance, and we really struggled with, you know, making sure that I was getting the pediatric care that I needed. So I wasn't diagnosed with irritable bowel syndrome for many, many years. And honestly, when I finally was diagnosed with a digestive disease, it was inflammatory bowel disease. And that was when I was 22 and finally had health insurance. But even before that, I had all sorts of extraintestinal manifestations of my inflammatory bowel disease. And I had all sorts of IBS, constipation-related symptoms, as well as GERD, acid reflux in my teenage years. My own IBD diagnosis trumped any need to explore other functional GI disorders. So the IBS went ignored. Any other issues around constipation and incomplete evacuation went ignored for many years because my Crohn's disease really was the bigger beast, so to speak. I had many, many surgeries over the course of a 7-year period from age 24 to age 31. I had over 20 surgeries, and I was dealing with a lot of psychosocial issues around having the Crohn's, including this being labeled a diet disease, and a lot of the cultural stigmas in the South Asian community around using medication, having surgery, living with an ostomy were sort of the bigger concerns at that time. But what I didn't realize is what a toll functional GI disorders can take during this time. So when did my SIBO diagnosis happen? It happened in 2015. I had come out of surgery, and you'll see to the right, me after surgery at the Mayo Clinic in 2015. I was having one of my last surgeries at the Mayo Clinic where they were correcting a J pouch excision. And my recovery in Minnesota kind of looked like this. It was very, very difficult for me to come out of that state. But that whole year, I was struggling with a lot of issues around constipation. Even with an ostomy, even without a colon or a rectum, I was having trouble going to the bathroom. And that's when my eyes started opening that there could be a real problem here because I was feeling obstructed all the time. So at this point in time, my doctors back in New York suggested, hey, Tina, maybe you want to consider a breath test. Your symptoms sound like SIBO. That's when I was diagnosed finally with IBS-C and finally with SIBO. What were my symptoms? Loss of appetite, abdominal pain, nausea, bloating, a lot of fullness after eating. I couldn't eat that much. And I was gaining this abnormal weight, even though I wasn't eating that much. And it just looked like a lot of bloat. Felt a lot of gas coming up. And this might be TMI, but there was also this sort of rotten egg smell coming from my stools. And that, was all indicative of small intestinal bacterial overgrowth, according to my GI doctor. So how did I manage and treat the SIBO? I think this has gone on for a number of years now. Since 2015, 2016, we've been trying various methods to control this. And at times it's worked quite well. More recently, it's not working out so well. So what I did was initially I changed my diet in 2015 and 16, and it helped me to go to the bathroom. And I really didn't have too many problems doing that diet change with a GI dietitian at my IBD center who monitored consistently, me cutting out certain foods and then reintroducing them when I was feeling better. What happened in the last few years, though, is my SIBO started to become more chronic, more refractory. And I went the herbal antibiotic route. I had used so many traditional antibiotics during my Crohn's disease journey and with all the surgeries that I had had. So I was recommended things like Candibactin AR/BR, Biocidin, things like that would help. And I had also cut out a lot of carbs and sugar to try to prevent the SIBO from flaring up. And I cycled on and off these herbal antibiotics for some time and did quite well. I also started to explore things like pelvic floor physical therapy and acupuncture for constipation. The pelvic floor PT helped with a number of other issues. I have pelvic floor dysfunction on top of that, given the inflammatory bowel disease and all the colorectal surgeries I've had. So pelvic floor PT really helped with a number of different things, but has also been key in helping with the constipation and getting things to move. Acupuncture has been instrumental as a complementary alternative therapy. Electroacupuncture specifically has been very helpful in getting things moving when I feel really stuck. During this time, though, I think it became clear, especially in the last 2-3 years, that there must be some kind of underlying motility disorder for me to have this bad constipation. So I started exploring this in 2018 in New York, wasn't really getting many answers, and finally reached out to my IBD specialist at Mayo Clinic, frustrated, saying, there's something going on with me. The traditional Miralax and other laxatives aren't really cutting it, and I'm having a lot of constipation. He brought me in, he did a whole analysis during this time to understand what was going on with me. I had a gastric emptying study. I had a small bowel manometry done. You can see the photos to the right. And he determined the gastric emptying study was a little bit tricky because what happens is, with an ostomy and without a colon or rectum, there were really no fair values. So it was tricky to do just a gastric emptying study. But with regards to small bowel manometry, they put 15 sensors from my esophagus down into my stomach and small intestine to see the movement that's going on there. And they found antral gastroparesis. So 2 years ago in June 2019, I was diagnosed with that. And that was kind of like, okay, this is what's causing your problems, Tina. But I was still kind of hesitant because I was thinking, you know, that's an upper GI problem. Okay, so I have some nausea. I do have fullness and bloating, but what's going on with my lower GI tract? During this time, I started a lot of meds for off-label medications to treat the chronic constipation, but also to treat the gastroparesis. And things started to move along smoothly. And I just assumed that things were getting better from here on out. About 18 months ago, right before the pandemic, I started having problems again. And I had broken my ankle pretty badly and stopped moving. And as you might know, motility tends to be impacted if you don't exercise or move much. During this time, things got very bad for me. I started to back up consistently. And with the pandemic arriving just a few months after, without much exercise or going many places, my motility was really impacted. Even though I went for walks daily, it didn't matter. Things were starting to get pretty bad again. I was dealing with SIBO the entire spring of 2020, and I was started on a regimen of these herbal antibiotics again, and cycling on and off, and changing them every single time. And I continued sort of the pelvic floor physical therapy and the acupuncture. And I started to get better come last summer and last fall as things were opening up, you know, in New York City. I started to get better. But I found that, you know, after some time, I started to develop refractory SIBO again. It came back in November. Thing is, I was put on crucalopride, I was put on pleconatide, domperidone, all these medications to help me go, but nothing was really quite cutting it. During this time, I started seeing a SIBO specialist in New York City who decided she wanted to do an upper endoscopy with a jejunal aspiration. So she did this in March, and I tested positive, heavily positive for SIBO, but also positive for CFO, which is small intestinal fungal overgrowth. Within a few hours of that upper endoscopy, I had a massive bowel obstruction. She had me hold my meds for a couple of days to sort of see what that growth would be like in my bile. And that's how she found the SIBO CFO. So this was considered the gold standard in terms of diagnosis, because it gave sort of the understanding of what kind of bacteria, what kind of fungus is growing in the gut, rather than a breath test, which just sort of indicates, okay, there is, you know, methane gas or something like that growing. It's not so much indicative, though, of the strains of bacteria or fungus that might be growing. So she really wanted to do this upper endoscopy, and I'm glad she did, although the bowel obstruction really was very difficult to get over, and it took days and days of medications and magnesium citrate to sort of resolve. Over the last couple of months, what's happened in the spring and now into the summer of 2021, I've been treated with rifaximin, I've been treated with diflucan, I've done a low FODMAP diet. You can see some of these photos of different foods that I was trying at home to cook that are lower FODMAP. I've been doing a lot more smoothies and low FODMAP fruits, low FODMAP vegetables. I am vegetarian. I am plant-based for the most part. So trying to work with this with my GI dietitian. I've done 6 weeks of the low FODMAP diet, and I am currently reintroducing foods, but now I'm feeling SIBO flaring again. So this is becoming one of those recurrent problems with me. And just last week, I was diagnosed with another motility problem. called chronic intestinal pseudo obstruction, which I believe is known as SIBO or CIP. And how did they come to this diagnosis? So between the upper endoscopy, and I also underwent an ileoscopy in May of 2021 by my surgeon through my terminal ileum, since I have no colon or rectum. He scoped my small intestine to, of course, look for Crohn's disease, but also to see if there was any mechanical source of obstruction that might be causing my the backups and the constipation and the SIBO. He said, Tina, I can assure you I've gone up 80 centimeters into your small bowel. There is no reason for me to believe that this is a mechanical issue. So once I found that out, we realized, okay, Tina's got a major small bowel transit issue. I am waiting to undergo further testing, but by a process of elimination, I've been diagnosed by 2 Mayo Clinic physicians who have said, this sounds and looks very much and presents like chronic intestinal pseudo-obstruction. So where am I right now? Right now, I have started pyridostigmine just in the last few days to see how I do. And I'm waiting to figure out how to deal with the SIBO. I am in the process of taking appointments with Cedars-Sinai to get to the bottom of this issue. As I understand, they have some of the world's best SIBO experts. I'm also awaiting further testing in New York City this summer. I've also been told that I may need some kind of chronic low-dose antibiotic to manage the SIBO, chronically speaking. But, you know, I'm not going to lie when I say that this hasn't been taking a toll on me. Emotionally and physically, as we are starting to come out of the pandemic, I'm just wondering how I'm going to manage this. My lifestyle throughout the pandemic and even before that has been every hour or two taking something to help me go. What's tricky and complicated about my case is that I have an ileostomy, I have Crohn's disease, I have all these other functional GI disorders. So trying to parse these out and figure out what's causing what symptom, but also trying to sort of deal with the fact that my ostomy is getting obstructed, the site is getting obstructed without there being any real source of obstruction, that's constantly causing the SIBO to flare up. That's constantly causing the bacteria to ferment because there are these obstructions going on due to the compromised nature of my bowels. So that's kind of where I am today, but I am going to say, just like I've been very persistent with my Crohn's disease, getting it resolved, going to the Mayo Clinic, undergoing the surgeries, joining a clinical trial to get this Crohn's disease better controlled, and I'm fortunate enough to be in remission now, I'm going to figure this out. I realize how heavy of a toll this has taken, but I also realize that I'm very persistent and that I will learn what I need to learn about SIBO and about all these functional GI disorders so that I can manage my care in the best way possible. Thank you so much.
Hi, and welcome back. I hope you enjoyed that final session of the day on H. pylori and SIBO, bacteria in the GI tract. I know those were some great talks from Bill Chey and Darren Brenner, and we did get some questions from the audience in our chat from those. So Lynn, I'm just going to start firing away if that's okay with you. All of you, we have introduced it, but if you're new to joining with us, this is Lynn Chang from UCLA. And so we've got a lot of questions from different places. So one of the things that came up, and this is kind of piggybacking off of your talk on IBS. So there are a lot of similarities between IBS and SIBO. People have been diagnosed with one and then the other. How can you better explain why are they so similar and what sort of makes the differentiation between the two?
Yeah, SIBO is a complicated topic. because there really isn't which stands for small intestinal bacterial overgrowth. There is actually no gold standard test. So there's some discussion and debate whether the way it's diagnosed, which is typically by a breath test, whether it's glucose or lactulose, if that's really representing true SIBO. Because the breath test can also be positive in healthy people, and it also is a measure of transit time. So the faster transit, it could be more of a positive test. But there are patients with true SIBO where typically they've always found it associated with some slower motility of the small bowel, or you know how you talked about diverticula of the colon, but people can have it in the small bowel as well, or partial stomach resection. So certain people are predisposed and they'll have symptoms that mimic IBS, the bloating, abdominal discomfort, abdominal pain, loose stools. But in some IBS patients, who have those symptoms, they can have a positive breath test. And the question is whether or not SIBO is the explanation for their symptoms. And if you treat it, will their symptoms completely go away? And even people with chronic intestinal pseudoobstruction, which Tina was diagnosed with, that's treated with cyclical antibiotics, meaning that for like a week per month, they'll treat with antibiotics because the underlying condition doesn't change. So the small intestinal bacterial overgrowth will recur. That's separate than IBS, where you don't really have chronic intestinal pseudoobstruction per se. So the symptoms mimic each other, but the question is SIBO the real cause of the IBS-like symptoms?
So very convoluted and something that you have to talk to your healthcare provider about to make sure you're getting the right diagnosis, which definitely differentiates the treatment between the two of those.
Right. Yeah.
So what sort of testing? So Darren talked about EMO, right? So the intestinal methane overgrowth, which is a new topic and sort of something that's breaking news right now in this field. And so what type of differentiations between SIBO and EMO should we be thinking about, and as patients may be asking about with their healthcare providers?
So when bacteria break down the food products in the gut, it causes the development or creation of gas, which is hydrogen or methane. Those are the two main ones. And we see more of hydrogen methane. But a standard, like for example, lactulose breath test can measure both hydrogen and methane. In patients that have more methane, greater production of methane, that has been seen to be more associated with patients with constipation. And different centers have found that rather than just the classic hydrogen. But there are some patients that you don't detect really increased amount of gas. And so another gas that's actually people are starting to do research on is hydrogen sulfide.
Oh,
yeah. So that's going to be a new one that we'll find out more about. But for the methane producers, it's more characteristic in chronic constipation or IBS with constipation. However, there have not been great randomized controlled trials on how you treat that.
Okay.
Like we have for IBS with diarrhea with the, positive test.
Okay. So I know that tomorrow we're going to really get into treatments and we're going to really talk about that. But we did have a question from the audience about rifaximin. And rifaximin is a very common medication that is prescribed for people with SIBO. And the question that we have is that how often can someone take rifaximin? And is there a danger of taking it too often or too many times?
Yeah, I think the one really important clarification is that rifaximin is only FDA approved for IBS with diarrhea. It's not actually approved for SIBO.
Got it.
Now, people may use it for a positive breath test, but the physician actually has to link the correct indication of rifaximin with IBS with diarrhea, and that's where all the data is.
Okay.
For the FDA approved indication of IBS with diarrhea, you can use it up to 3 times because this is based on a rifaximin retreatment trial. And they don't tell you in what period of time that you do the treatment, but it's been shown that you can treat up to or approved up to 3 times. Now, if somebody has a positive lactulose hydrogen breath test, that enriches and increases the chance that a patient with IBS with diarrhea will respond to rifaximin, about 69%. Overall, if you have IBS with diarrhea, you respond to rifaximin positively in 40% of the patient population in clinical trials, in large clinical trials. If you have a positive breath test, then there's about 69% that will respond to rifaximin. So you increase the chance. If you have a negative breath test, it's about 26%. So that helps guide you on whether, now this is based on 93 patients, so it's not a large group of patients. Now, people also don't know exactly how rifaximin works. It's presumed it's reducing the bacterial load and you're treating SIBO, but we don't know if that's true. It also has anti-inflammatory properties. It could have effects in the colon. So you just want to make sure we're clear on the data of rifaximin in IBS diarrhea. It's not in SIBO per se.
Got it.
So I think that's important for people to know.
Absolutely. Absolutely. I actually wasn't aware of that. So thank you for clarifying that. And so to answer the question about how many often can you take it? It's not really an often. The FDA has approved it for 3 times maximum in a patient. So great information. Thank you so much. And then also Tina mentions SIFO. So that's the fungal overgrowth. Can you tell us a little bit about what that is? And there's a lot of overgrowth things that we're talking about here today. So can you talk a little about that?
Yeah. So as I said, that people have done lactulose or glucose hydrant breath testing for positive diagnosis, presumably due to SIBO. But the other way of detecting it is actually due to an endoscopy, or you can take a tube and aspirate fluid in the small intestine, the upper part of the small intestine, and you culture it and you see how much bacteria. And there's a certain criteria that they use for small intestinal bacterial overgrowth. But now you can actually test it for fungus as well. Same aspiration in the small intestine, collect the fluid. And so there is not as much data on this, but there is some data, not nearly as much as for SIBO, that you maybe find fungal organisms like, say, Candida, and that it could also explain these IBS-like symptoms. There hasn't been enough data to know that if a patient has that and you treat them with the antifungal medication, will they get better? I think there's some evidence, but not really in randomized controlled trials as I know of. But also, just even a positive duodenal aspirate for SIBO or the SIFO, age, if you're on a proton pump inhibitor, if you have slower motility, that all can also cause a positive test. So I think that the patient and the healthcare provider should take that information and think about the factors that can affect a positive test as well. So that's something that we'll probably get more information, hopefully. Also antibiotic use.
Right.
That would affect it as well.
So, just to clarify, would these types of fungus or fungal organisms, will they be naturally found in the digestive system? Or is this something to be alarmed if your healthcare provider tells you have SIFO?
Yeah, see, this is always the interesting part, is whether or not a organism that we naturally have, like Candida, we naturally have that, if that's really causing the symptoms, if it's allowed to grow more. Because if you're on antibiotics, you're going to suppress the bacteria and you're going to more allow the Candida to grow. That's the same as C. difficile colitis.
Right.
We have C. difficile, but if you're on antibiotics, it allows that to grow and take over and cause colitis. H. pylori is an organism that, we talked about, that we also have in our stomachs. And in many people, it causes no symptoms. So you don't really need to treat it per se. But in certain individuals with a certain number of factors that come together, it causes symptoms. And if you treat it, they can get better. So that's something that we all have to think about is this a consequence? Is it really explaining the symptoms? And you have to take a lot of factors in mind when you're approaching a patient with this.
Absolutely. And so talking about H. pylori, so understanding from Bill's presentation that originally those were considered like stomach ulcers, right? So that was sort of the peptic ulcer disease, and that was the sort of the early understanding of H. pylori. And I understand that, with the ulcers left untreated, sometimes they can bleed. And then you can have a really big problem in your stomach. What sort of symptoms should patients be thinking about? So some people have H. pylori and they think they have GERD, or they're being treated for something else. What are some things that would say, you know what, I probably should go to my doctor and find out about this before it becomes something that like a GI bleed?
So H. pylori is associated with ulcers, but ulcers are also associated with medications like ibuprofen, aspirin. So when you see someone with ulcers where they have pain, and it could be, when they haven't been eating, and food could actually relieve it. And they could have bleeding, and sometimes they don't have bleeding, but that can be associated with H. pylori, and you have to treat the H. pylori because that reduces the risk of getting recurrent ulcers. But H. pylori is also associated with dyspepsia. And that basically means that, above the belly button in the upper part of the abdomen, the patient has burning discomfort or pain. That's what dyspepsia means. And studies have shown that there's two ways to go about treating it. One is to detect if you have H. pylori, and you can do that by a stool test now, a breath test. You don't have to do an upper endoscopy. And if they have it, you treat it. And if you treat it, there is a small but statistically significant chance the patient will have relief and resolution of the upper gut symptoms. The other pathway is to take a proton pump inhibitor, like omeprazole, pantoprazole. A lot of those are over the counter. And if that heals and resolves their symptoms, they could have had inflammation or an ulcer. You go that way. Then functional dyspepsia, which we're going to talk about tomorrow, is where you have dyspepsia, but you do a procedure like an upper endoscopy and you don't see an ulcer. You don't find anything to explain their symptoms. So we call it functional dyspepsia. And that has also been associated with H. pylori. And so if you detect H. pylori by doing a biopsy, a piece of tissue, you do an endoscopy and find H. pylori, you also treat those patients who have it with functional dyspepsia. But if someone's having really bothersome pain, they're taking those over the counter, omeprazole or famotidine, or they vomit, maybe they're having blood, or they have dark stool, like black color, like your or my hair, then that's a sign they could have bleeding, and they should definitely see a doctor, or they're dizzy or lightheaded. But anything like we said earlier today, really bothersome symptoms, they're not getting better with over-the-counter remedies, or they're just concerned, you should seek healthcare.
Fantastic. Absolutely. And thank you so much, Lynn. I really feel like this is such a big topic right now, and there's just so much to learn. And I just really learned a lot from Bill's talk for sure. So this was our final talk of the day, and we are going to be closing out. And we really hope you enjoyed our programming today, and that you will join us again tomorrow for the second half of the Norton Educational Series 30th anniversary edition.